People often tell the doctor what they want to tell the doctor, which is good. But at a certain level, especially at the beginning, you got to stop and say, no, 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 no. I'm not going to tell the doctor what I want to say. There'll be time for that. Right now, I want to figure out, what is he trying to get from me?
Dr. Jonathan Bakhtari.
You can see it. I mean, it's crystal clear.
I think it's going to really revolutionize things.
Which is a big game changer.
Hi, welcome to another episode of Bakhtari MD. Today, we're going to talk about common mistakes people make when they go see their doctor. In other words, what can we do to get the most out of those visits? You know, one of the most amazing things I am always confronted is when I refer someone to another doctor, or when friends or family are telling me about a doctor visits. You know, when I ask them, so what was the final upshot of the visit? What did the doctor say? You know, he didn't really say. And, you know, I struggle with that. I don't think many people go to see the doctor and they tell the whole story and the doctor says, well, that's amazing. Great. I'm leaving. Thank you. The doctors do say stuff. I mean, it's unheard of to not have a visit where the doctor doesn't give you an idea of what might be going on. But there is obviously something going on there. And I think there are things patients can do to be better prepared for the doctor visits and to also understand how a doctor's mind works, his or her mind works. Because if you understand what they're trying to do, it'll help you prepare. So the first thing I want to talk about is when you go see a doctor, I think there is a tendency for some people to go there for a main reason, unless it's an annual checkup, but then say, you know, I wonder how many more issues I can add to this list, which sometimes is really a good thing if your main complaint is nothing serious. However, if you have a serious concern, you have to really be picky about how many secondary and third issues you want to add to that. For one thing, you have to understand no matter how long your doctor visit is, you have a limited amount of time. And I think you need to make a calculation, whether it's 10 minutes, 20 minutes, or even an hour. You have to make a calculation. How many issues do I want to bring up on this one visit? Now, it may be that you may have to make more than one visit if you have multiple issues and you really want the person, the clinician, the physician, the PA, nurse practitioner. If you want them to focus on one issue, that's a decision you got to make, because a lot of people kind of feel like they're going to the grocery store and, you know, I'm going to pick up some apples and I might as well pick up some asparagus and beans and tomato sauce. And that kind of makes sense in a grocery store. But in a physician's office visit, sometimes it can be counterproductive to raise multiple issues, unless, of course, they're serious. I mean, if you're really having serious issues, yes, of course. But this is not the time to get every nagging request fitted into the visit and, you know, what they think of your current vitamins that you're taking. And again, if you've got not much else going on, maybe bringing up your vitamins is a good thing. But that may not be the perfect visit if you're having severe abdominal pain and what have you, to be bringing up other issues like, hey, what do you think of this other therapy? You know, I'm doing some meditation and yoga. What do you think of that? Which is all good in a normal primary care visit. But if you are coming in with a serious issue, you have to pick and choose what you want the doctor to focus on. After all, your doctor, your physician, or your PA, or nurse practitioner, he or she is human. And they're seeing whether it's 10, 15, 20 people a day, each one with multiple concerns. There is a limit to how much they can process. And when I say process, they might be able to process a lot, but you want them to really process in a more focused way sometimes, especially if something is very important to you. So number one, pick and choose what you want to discuss. And certainly if it's time sensitive, yes, bring it up. Otherwise, consider maybe making another visit, or if you're seeing a specialist, maybe bring something up that should be brought up with your primary care doctor, not with the specialist, but with your primary care doctor. And I see that all the time as a specialist, where people would say, hey, what about my weight issue or something? And I say, yeah, that's a great idea, but let's have you take that up with your primary care doctor. So also understand who you're seeing. So if you're seeing your orthopedic surgeon, now they may say, yeah, losing weight might help your knee issue. And so that might come up, but really more often than not, it's going to be your primary care doctor who's going to deal with the strategies for losing weight. So understand who you're seeing and what their purview is, what area that you want to bring up with them. So if you're seeing your cardiologist, maybe that's not the right person to bring up. By the way, your knees are still struggling or what have you. So, and I think, that kind of example, people get it, but you'd be surprised how many issues are brought up to specialists, which obviously fall under the purview of their primary care doctor. So be aware of that. But even within that realm, so you go in and say, okay, whatever it is, my doctor has 15 minutes with me. What can I do in that 15 minutes to get the most out of this visit? And one, obviously focus on the main 1, 2, or 3 issues you have, but not an unlimited number. And then let's talk about what you need to do to prepare. So if you're going to go see a doctor for knee pain, abdominal pain, you have to understand when you walk into a doctor's office or a clinician's office, he or she will be trying to figure out in a broadest sense how important or how serious your issue is. So if I walked into a doctor's office and I say I have abdominal pain, the doctor walking in doesn't know if you have a ruptured appendix and you're sitting in his office with a ruptured appendix, or you just have an anxiety disorder, which can sometimes cause functional abdominal pain. Or you may have a brand new disease that he has to diagnose, ulcerative colitis, inflammatory bowel disease, or you may have something as mild gastritis or just a little infectious diarrhea. So you have to understand, when they walk in and they see your chief complaint is abdominal pain, their mind is racing between, oh, I have to get this person to an emergency room, to I just have to reassure this person. So there's the whole spectrum. And when they walk in, they're really only focused on which way should I be going. So they're going to ask you some very rapid fire questions, not in the sense that they want to know exactly with extreme precision what the answer is, but in broad strokes. So how long have you been having the pain? I don't think they really care if it started last Thursday at 4 o'clock. And I don't think by you spending 30, 60 seconds figuring out exactly what day 3 weeks ago it started on, it doesn't really matter. What they want to know is did the pain start 3 weeks ago, or has it been around for a year, or did it start like yesterday morning? And I think what I see sometimes patients do is agonize to be precise. And I think what they don't understand is sometimes doctors do want precision, sometimes they don't. They don't want precision. And if you're taking 30 seconds to answer every question precisely, that's going to run out the clock at some level, right? If you have 20 minutes, you have 20 minutes, and you're probably better off saying, how long has the pain been there? Well, roughly 3 weeks. I think that's a good enough answer for most doctors. And again, we're talking about pain, but it could be anything else. Or is there anything that makes the pain better or worse? Well, let me see. I don't know. I think, maybe when I stand up. No, not when I stand up. More like, that kind of precision is not necessary. They just want to know if the pain gets worse with movement, with eating. Really broad answers, not precise answers. Now, there are times where physicians and clinicians want precision. And this is where you have to be kind of picking up on when they want you to be precise. But usually I would say the beginning salvo of questions that even the nurse that might see you before the doctor comes in, that initial salvo, often they want accurate, but they don't need precision. I just want to take a minute here. And if you've been following my channel, we cover a broad range of topics, including, insurance, how hospitals work, what to do in the ER, COVID, and what have you. And, a lot of that relies on my 20 years of experience being in the medical field, being a clinician, assistant professor, and a clinical professor of medicine, medical schools, as well as being an entrepreneur, being a hospital administrator. I bring all of that experience to bear So I really need your help about what other topics you want me to cover. Some of the topics we've already covered have come from suggestions from people like you, also friends, family, and viewers. So please leave in the comments section below other topics in medicine that you would like us to cover, whether it's insurance, whether it's picking doctors, how to talk to doctors like we did today, and other related healthcare topics. I'm more than happy to create those videos so you can have that information. Just let me know below what you would like us to cover. Thank you. When a doctor or clinician is walking in, they're running an algorithm through their brain, and yes or no answers to different things leads them completely in a different direction. So by you saying pain's been there for 3 weeks, that puts it in a different category than if you say the pain started this morning or whatever symptom we're talking about. If you say you have fever or you don't have fever associated with the pain, that puts it in a completely different category often. So what they're trying to do is literally it's an algorithm. If you've seen algorithms and how algorithms work, physicians and clinicians' minds when they're going through that initial thing is an algorithm. They're trying to say serious, not serious, how serious, and then in the spectrum. And then later on, I think they actually drill down and have a more precise idea. When I was in medical school, one of my professors told me, and I didn't believe it at the time, that he said that he could make the diagnosis 90% of the time within 5-10 minutes of talking to the patient. And I didn't really believe that. I thought, well, no, it's going to take more time because you have to do a physical exam and you have to do laboratory testing and diagnostic testing. And what his argument was that, no, we do all of that to confirm what we think. It's quite interesting. So I think what you'll see is almost like an aha moment in a lot of clinicians' mind as you're blabbing in the first 5-10 minutes, as they get a sense of awareness of what they're dealing with. And so you want to kind of go along with that and give those accurate but not super precise answers, like, is there any kind of food that makes it better or worse? I don't think they really care exactly, but just in broad strokes. Yes, spicy foods make it worse, and bland food makes it better. They want it in broad categories at that point. And for you to walk into that visit and understand the first 5-10 minutes of either the nurse interviewing me and or the doctor or the clinician, he or she is going to be trying to go through an algorithm. And what can I do to speed that algorithm along? Because the sooner you can help the clinician get down to the kernel or essence, the more time of that visit you can spend talking about, okay, so if we think this is what this is, what are our alternatives? What kind of testing do we need? What kind of treatments are there? What are my options? How will we know? I'd rather spend more of my time focused on what the clinician thinks is the issue and what that means and what that entails, what the prognosis is, if that is the case. Well, what kind of testing do we need to do to find out if that's the case? And what happens if that test is negative? What happens if that test is positive? What are the alternatives to that? And so I find that patients who are able to get their clinicians to sort of that home stretch and spend more of the visit on the home stretch, as opposed to the clinician trying to get the patient to focus on what information they need. It's sort of like, don't give me the information you want to give me, although that's important. It's important to, get out things that have been bothering you. But initially, try to give them the information they want or they're trying to get from you. People often tell the doctor what they want to tell the doctor, which is good. But at a certain level, especially at the beginning, you got to stop and say, no. I'm not going to tell the doctor what I want to say. There'll be time for that. Right now, I want to figure out, what is he trying to get from me? He's asking me, when the pain started or when the nausea started, whatever. I think he just wants a broad answer. I don't think he really cares it was 3 o'clock last Tuesday. I think he just wants to know if it's been going on for a week or a day or a month or a year. If you understood how that algorithm works, you wouldn't be that precise. And then yet there are other times later on in the conversation where we want precision. I think the level of precision that clinicians want, in my experience, increases as the conversation goes on. So initially accurate, but not super precise. Precise, but not super precise. But as they get closer and closer and closer, then we want more and more precision. So your knee hurts more when you turn to the left or to the right or backwards or both. I mean, sometimes we do want a lot of precision, but initially we just want trends or broad strokes of how things are going. And if you'll notice during a typical doctor's visit, if traditionally the way I've seen it, as a conversation goes on, you'll see your clinician asking for a lot more precision as you get further down the algorithm, tree. This does not mean that you should not ask or bring up topics you want to talk about. But I think once you get to that point, then say, well, doc, that's all great, but I just want to also let you know this may be nothing or maybe something, but these are the three things I've noticed, along with this pain. I don't know if that's something or nothing. I know you didn't bring it up, but that's also happening. So it's very important to be thorough and complete. So you have like two masters, right? On one hand, we're asking you to try to give the information the clinician's asking for and not extraneous stuff. But the flip side is you can't leave out extraneous stuff because sometimes that might be important. So if you feel that there's extraneous stuff that wasn't asked, very, very important, when or at the right time, often near the end or somewhere in the middle, just say, by the way, just so you know, just want to share these other three things that I've noticed. So it doesn't mean you're just going to be just saying following like you're like playing a violin and there's a maestro telling you what to do. At a certain point, it's very important that you express any and all of your concerns, story, or issues with your clinician. After you give that information, if you do have concerns that they didn't bring up in their questioning, of course bring it up, of course add to it, of course press down on other issues that you want to know about. But understand initially what they're trying to do is get to what they think is the core issue, and then spend as much time once you get to the core issue to see how confident they are that's what it is. What's the differential diagnosis, which is medical lingo for what are the top 3 or 4 things it could be, and how likely is it to be number 1, 2, or 3? Those are the kind of questions you can ask. So, often I think when patients come back to me and say, well, I went to see that specialist you sent me, but he didn't really say much. I think part of it is they may say stuff to you, but I think it's important for you to then spend as much time during that visit to get them to drill down, put it in layman's term, explain to you what it could be, what it can't be, what are the options, what are the diagnostic testing that's going to help, if any, to sort it out. And if it does turn out to be this, what's the prognosis? What's the treatment? And spend more time. I think if you can spend more of your visit on that part of it, as opposed to the algorithm part where the clinician is drilling down, I think you're going to get a much more fruitful visit. When your clinician does give you, the feedback that you've been looking for, if it doesn't make sense to you in the sense that if he or she is using jargon that you find difficult to understand. If you go for knee pain and then your doctor says, well, I think it's degenerative joint disease. I think it's a fair question to say, doc, help me understand, what is degenerative joint disease? What is cartilage? Cartilage, bone? Break it down for me, if I can use that term. Tell me, what is cartilage? What is bone? And what is degenerative arthritis? And how does that work? And why am I having it? And, did I do something to get it? You should walk out of that visit in a way that you could go on YouTube and explain to everybody what's going on in your knees. It should be that simple. And I think that's what you need to ask for. After you help them get to where they need to get, then you need to ask for help back and say, listen, break it down for me. I just gave you all this information. And so now tell me, what does this mean? What is it exactly? What does it mean for me? And what's it going to be like? What are we going to have to do? What's it going to be like in 5 years? What's the long-term view of this thing? Explain to me in a way I can explain it to my wife, to my significant other, to my children. What's going on? And I think, the amazing thing about clinicians that I have found is when given an opportunity, an open-ended opportunity to dumb it down, if you want to call it that, but just break it down in simple terms, we all love to do that. And I've rarely met a clinician who, if given an opportunity, doesn't enjoy taking, their vast book knowledge and breaking it down into just really simple layman language. So I think you'll be surprised. Ask your clinician, your PA, nurse practitioner, physician, ask them to break it down in ways that you can understand and take home, not only what it is, but what it could be. If it's this, what's that? What are the options for treatment? And, what do the treatments mean? What are these medications? What kind of medications are they? What class are they? How do they work? These are all. So I would love to spend the majority of the visit talking about that. And this is why I'm a big proponent of getting through that initial part fast. So rapid fire, answer the questions as quickly and accurately as you can, so you can spend the majority of that time in this, what I call the juicy part of the visit, where you get real value out of your visit with your clinician. Thank you for watching. Make sure you comment, like, and subscribe if you enjoyed this video. If you have any questions about this topic, or you want me to cover any other questions, please leave it in the comments section below. Also, check out my website, Bakhtari MD, and sign up for my newsletter, as well as more content like this. Thank you and be well.